Hello, my name is Andrea Guillén. The topic is immunotherapy in renal cell carcinoma. Definition: renal cell carcinoma is the third type of urologic cancer and has a poor prognosis with 30% of metastatic patients of diagnosis. Immunotherapy with checkpoint inhibitors is now considered a standard of care for the frontline treatment of advanced renal cell carcinoma. Despite better outcomes with these agents, there is still room for improvement.
I think when we look at the treatment for advanced renal cell carcinoma, it certainly has changed significantly. In the past several years, renal cell carcinoma doesn't respond to traditional cytotoxic chemotherapy, and we had the advent of the first target therapies with the VEGF TKIs, over now, I guess, close to 15 years ago, that really showed an improvement in progression-free survival. And then for a while, that was the mainstay. And then, back in 2017, we saw the first data showing that immunotherapy has a role in the frontline treatment with the presentation of that for Nivo and Ipi showing improvement in overall survival in immune poor risk versus sunitinib. And then since then, we've had other VEGF IO combinations with both axitinib pembrolizumab and axitinib adalimumab approved by regulatory agencies, given, in the case of acti-pembro, improvement in overall survival and progression-free survival versus sunitinib in all patients in the kind of risk group, and with axitinib improvement in progression-free survival. And so, there's a wide variety of options to offer our patients now. With, I think, TKI monotherapy being used less and less, given this data, and both, Nivo, Ipi, Axi, Pembro really becoming a new standards of care, given the overall survival benefit of patients with renal cell carcinoma.
Applications in medicine. The tyrosine kinase inhibitor sunitinib has been the standard of care in renal cell carcinoma for many years. The development of tyrosine kinase inhibitor, mainly vascular endothelial growth factor receptor inhibitors, largely improve the prognosis of both progression-free survival and overall survival.
So the next wave is these checkpoint inhibitors. There's at least 4 or 5 trials that I know of. I think only one with atezolizumab that's actually up and running. Others with nivolumab and durvalumab, and also, any drug you can imagine will be tested in that setting. It probably makes a lot more sense. It's going to be better tolerated for patients, I think. I think probably has the potential to extend overall survival, which would be ideal, which we haven't done to date, even with S-TRAC. And so we'll have those results in many years, but I think probably if we're sitting here in 5 to 10 years, we'll be talking about those drugs as standard of care.
Pros and cons. Identifying biomarkers is the key to better select treatments, reduce costs, and improve survival in patients with metastatic kidney cancer. In Italy, first-generation immunotherapy with cytokines, interleukins of interferon represented standard approach, but with poor results.
Checkpoint inhibition, that is actually a form of immunotherapy. So that whole class of therapy, what it essentially does is ramps up your own immune system and releases the brakes that the tumor created to slow down your immune system from fighting your own cancer. It lets go of the brakes so that you can fight the cancer yourself. And when it works, it is actually astounding. It's really quite remarkable. It doesn't work for everybody, but when it works, it's really quite remarkable. Well, interestingly, checkpoint inhibition, again, this immunotherapy approach, that has exploded on the scene for bladder cancer as well. And that is rapidly changing the paradigm for the management of advanced bladder cancer. And so there's active trials ongoing right now trying to figure out exactly what space that therapy should fit in. Should it just be in metastatic disease, or does it have a role in locally advanced disease or even earlier stages? So that is probably the single biggest advance in the last couple of years, and it's just taking bladder cancer by storm.
Issue applied in Ecuador. Renal cell carcinoma is a thyroidal cancer accounting for 3 points of all cancers in women and 5 points in men, with an incidence of around 400,000 cases worldwide. The prognosis is poor. 30% of patients are metastatic at the time of diagnosis, and almost 30% of the rest of the patients will develop metastasis detected during follow-up, as in Ecuador. Other topic is Ribavirin for chronic hepatitis E virus infection in transplant recipients. Definition: Hepatitis E is a liver disease caused by infection in virus. The virus has at least 4 different type genotypes. 1, 2, 3, and 4 genotypes 1 and 2 have been found only in humans. Genotype 3 and 4 circulate in several animals without causing any disease and occasionally infect humans.
Our lab studies hepatitis B and E viruses, which cause about 300 million infections worldwide and kill almost 1 million people annually. Neither one has a cure. We have developed new screening systems to identify new drugs to cure these viruses. Both hepatitis B and E viruses affect the liver, but they are very different viruses. Hepatitis B virus is transmitted through the blood and other bodily fluids. It enters liver cells where it hides in the nucleus. We try to find drugs that can kill this virus without causing harm to the patient. Hepatitis E virus infects people through contaminated pork meat and water. It stays within the cell body. We try to find molecules that can stop the virus from making copies of its genome. Our screening systems are faster and safer than existing platforms. Our systems are high throughput, meaning that we can screen millions of compounds within a short period of time. We modified both viruses so they are safe and robust for screening. The screening system closely mimics the situation in patients with chronic hepatitis infections. With these screens, we hope to provide cures for viruses that cause serious global health problems.
Applications in medicine. The hepatitis E virus is transmitted mainly through fecal route due to fecal contamination of drinking water. This route accounts for a very large proportion of clinical cases with this disease. The risk factors for hepatitis E are related to poor sanitation, allowing viruses created in the gases of infected people to reach drinking water supplies.
Hepatitis
hepatitis E virus, referred to as HEV, is a common cause of sporadic and epidemic acute liver disease in developing countries. In the United States, sporadic cases of both imported and locally acquired HEV infections are mostly seen among adults. Incubation ranges from 15 to 60 days following exposure, with an average of 40 days. Liver enzyme elevation, as shown in blue and labeled ALT for alanine aminotransferase, usually occurs 4 to 5 weeks after exposure to HEV and persists for 3 to 13 weeks. Symptoms noted by the purple bar occur when liver enzymes are elevated. Virus excretion in stool, illustrated by the orange bar, is variable, but usually lasts from about 1 week before symptoms appear until about 1 week after they have surfaced. However, this time frame can be longer in some people. Viremia in acute self-limited infections, shown by the green bar, can be detected about 3 weeks following exposure or a week or so prior to onset of symptoms and lasts for about 2 weeks. Antibodies to HEV, both IgM anti-HEV, depicted by the pink hatch line, and IgG anti-HEV, illustrated by the black hatch line, are usually positive about 3 to 4 weeks after exposure. IgG anti-HEV persists, but IgM anti-HEV declines rapidly during early convalescence and is usually negative by 13 weeks. HEV serologic testing in persons with acute hepatitis for which other causes have been ruled out may be performed, especially in someone who has recently traveled to an area where HEV infection is more common. Chronic HEV infection is rare, but has been increasingly recognized in immune-compromised patients. Immunoassays to detect anti-HEV are commercially available, but are not FDA approved. Nucleic acid tests for the detection of HEV RNA are performed in research labs, but are not commercially available. This segment is now complete.
Pros and cons. In rare cases, acute hepatitis E can be severe and result in fulminant hepatitis, acute liver failure. These patients are at risk of death. Fulminant hepatitis occurs more frequently when hepatitis E occurs during pregnancy.
So now let's meet some patients so we can put to work what we have learned about hepatitis E diagnostics. Our first patient is Hannah. She feels sick and had to vomit at home. She's feverish and her skin has a yellowish color. Her symptoms started 1 week ago. 4 weeks ago, she came back from Mexico when she visited family. Obviously, we think about hepatitis. Let's order lab tests. In Hannah's lab report, we can see that her liver enzyme function is significantly elevated. Furthermore, her hepatitis E tests are positive. Hepatitis E RNA is also detectable. So what's your diagnosis? Hannah has no history of immunosuppression. So let's take a look back at the graphic dealing with immunocompetent patients. Her ALT is very high, which signifies serious liver damage. Anti-HEV IgM and IgG are both positive, and we could detect RNA in Hannah's stool. Based on these results, we can conclude that Hannah is most likely in the early phase after infection. So Hannah is suffering from an acute hepatitis E infection. Let's see our next patient. Our second patient is Pete. He suffers from abdominal pain of recent onset. In the lab report, we can already see elevated liver enzymes. Pete received a lung transplant 8 years ago. Currently, he is on immunosuppressive therapy. Furthermore, he tells us that he's a passionate hunter. Based on Pete's history, we include hepatitis E screening in our lab report. We can see that his liver enzyme function is significantly elevated. His anti-HEV antibodies are negative. However, the lab detected HEV RNA in Pete's stool. What does that mean? Since we know that Pete is taking immunosuppressive medication, we should consider this in interpreting his lab results. We know that immunocompromised patients can have problems producing antibodies to the virus. So in Pete's case, it is essential to measure RNA. His lab report shows elevated ALT levels as a sign of liver damage, but negative antibody tests. However, there is RNA detectable in his stool. Pete is suffering from an active, ongoing HIV infection. Based on the laboratory findings, we cannot determine when Pete was infected. It may have been recently or more than 6 months ago. However, it is not important to know that. What is important is that Pete gets appropriate treatment and follow-ups. Congratulations! Now you can handle hepatitis E lab results.
So I hope you liked this video. Absolutely make sure to check out the course this video was taken from and to register for a free trial account which will give you access to selected chapters of the course.
Is what play in Ecuador. Every year these are an estimated 20 million infections worldwide related to an estimated 3.3 million symptomatic cases of hepatitis E. In conclusion, Ribavirin as monotherapy may be effective in treating chronic HIV infection. A 3-month course seems to be an appropriate duration for this therapy. Short and longer therapy can be given to heavily immunosuppressed patients and those who still have viremia 1 month after the initiation of therapy. Thanks.